everyone. Good afternoon. This is Dr. John Bennett broadcasting from Miami Beach, home of neuroanatomy.tv. We are graced with the presence of a world-renowned neuroanatomist, neurosurgeon from Mexico City. We've done lots of webcasts in both Spanish and English in neuroanatomy, and he's one of the founding fathers of neuroanatomy.tv. So, and also I'd like to introduce Warlix. Warlix, you say hi. Warwick has done all the graphics for us. Say hello, Warlix.
Hi everyone, I'm neurosurgeons from Thailand.
Okay, it's nice to have her here as part of the team. Okay, Victor, welcome, and it's all yours.
Thank you so much, John Bennett. Can we start?
Yes, please.
Okay. First of all, thank you, John Bennett. You are doing a great effort for all the world community in neurosurgery. This is a honor for me to be invited for you, and thanks everybody. Today we are going to talk about supratentorial arteries. What I am doing here in Mexico, I am working in Forensic Sciences Institute in order to make some dissections of brain. For example, in this case, I am injecting some silicone in order to see much better the veins and also the arteries. In this injection, we can see the Labé vein, the trolar and sylvian. And we can see also a very nice anastomosis. Well, in the next video, I can show you the injection of some arteries of the brain, the M4 segment of middle cerebral artery. Okay. I think I have a problem because I can see all the screen. Okay. Supratentorial arteries include the supraclinoid portion of the internal carotid artery. This short segment is the supraclinoid segment of the internal carotid artery. This is giving rise to the anterior and middle cerebral, ophthalmic, posterior communicating, and anterior choroidal branches. The components of the circle of Willis, which in the posterior midline include the basilar apex and finally the posterior cerebral artery. The origin of all of these arteries is located deep under the center of the cerebrum, and their proximal trunks are relatively inaccessible because they course in depth clefts like these cisterns, ambient cisterns. So in here picture, you can see the supraclinoid carotid artery, anterior cerebral artery, anterior communicating, posterior communicating, and posterior cerebral arteries. This is basilar apex, and P1 in each side. This is a hypoplastic branch of this P1, and this is known as a fetal variant of posterior communicating artery. The segments of the internal carotid artery. The internal carotid artery is divided into 4 parts. The C1 or cervical portion, like in this draw. The cervical portion extends from its junction with the common carotid artery to the external orifice of the carotid canal. The C2 or petrous portion courses within the carotid canal and ends where the artery enters the cavernous sinus. Like in this case, this is the petrous segment, and here we have the cavernous segment of this internal carotid artery. The C3 or cavernous portion courses within the cavernous sinus and ends where the artery passes through the dura mater, forming the roof of the cavernous sinus. In this case, here we have the supraclinoid, and here is the end of this intracavernous carotid segment. And the C4 or supraclinoid portion begins where the artery enters the subarachnoid space and terminates at the bifurcation into the anterior cerebral artery and middle cerebral arteries. The C4 begins where the artery emerges from the dura mater, forming the roof of the cavernous sinus. It enters the cranial cavity by passing along the medial side of the anterior clinoid process and below the optic nerve, like in this picture. It courses posterior, superior, and slightly lateral to reach the lateral side of the optic nerve and the optic chiasma, and bifurcates below the anterior perforated substance at the medial end of the sylvian fissure. This is the medial end of sylvian fissure. And in this artery is giving rise to the anterior cerebral artery and middle cerebral artery. The ophthalmic artery is the first branch of C4. Most ophthalmic arteries arise below the optic nerve, as you can see in here. This is a picture in which we can see the cellular region. Here we have the pineal gland, the intercavernous sinus, and here we have both supraclinoid carotid arteries, the left and the right. In the right side, I cut the optic nerve in order to see this, the beginning of this ophthalmic artery. 8% of ophthalmic arteries could originate within the cavernous sinus, and this is rarely absent. The ophthalmic arteries uncommonly give rise to intracranial perforating branches, and if present, these branches run posteriorly and are distributed to the ventral aspect of the optic nerve and chiasma and the pituitary stalk, as you can see in here. But they are very, very small arteries, like here. The posterior communicating artery forms the lateral boundary of the circle of Willis, arises from the posteromedial surface of the C4 approximately midway between the origin of the ophthalmic artery and the terminal bifurcation. It sweeps backward and medially below the tuber cinereum above the sella turcica and slightly above and medial to the oculomotor nerve to join the posterior cerebral artery. Here you can see these components of the circle of Willis. Like in this, we have the right supraclinoid carotid artery, middle cerebral artery, and above the optic nerve, we can see the anterior cerebral artery. In here, we have a hypoplastic posterior communicating artery, like in the other side. In both sides, we have a hypoplastic posterior communicating artery. Here we can see the basilar artery, P1, P2, and here we have the middle cerebral artery and some early branches of this middle cerebral artery. Another artery that we can see in here is the anterior choroidal artery. Here we have this artery. Then first we have the ophthalmic artery, the posterior communicating artery, and then the anterior choroidal artery. The premammillary artery is the largest branch that arises from the posterior communicating artery. Here we have the mammillary bodies, here the chiasma, and here the optic nerves. So this is posterior communicating artery. And as you can see in this picture, we have this largest branch that is coming from this posterior communicating artery. This is known as the premammillary artery. It enters the floor of the third ventricle in front or beside the mammillary body, between the mammillary body and optic tract, as in this case. There are commonly 2 or 3 branches terminating in the premammillary area, but only the largest branch is referred to as the premammillary artery. The premammillary artery has also been referred to as the anterior thalamoperforating artery. The premammillary artery most commonly originates on the middle third of the communicating artery. This is almost in the junction of anterior and middle third of this posterior communicating artery, but can also arise on the anterior or posterior third. It supplies the posterior hypothalamus, anterior thalamus, posterior limb of the internal capsule, and subthalamus. The classic reported clinical features of occlusion of the anterior choroidal artery are contralateral hemiplegia, hemianesthesia, and hemianopsia. Here we have the anterior choroidal artery. I have removed some parts of the temporal lobe, and in order to see the trajectory of this anterior choroidal artery. This artery has 2 segments. One is the cisternal segment, like in this case, and the other one is the plexal segment or choroidal segment. So here we have the posterior communicating artery, anterior choroidal artery, and several arteries that are coming from the M1. They are known, they are the lenticulo-striates arteries. The contralateral hemiplegia and hemianesthesia to all sensory modalities results from infarction in the posterior 2 thirds of the posterior limb of the internal capsule and the middle third of the cerebral peduncle. The homonymous heminopsia of varying degrees results from interruption of this the anterior choroidal artery. The reason is here. Here we have the optic tract. After the chiasma, we have the optic tract, and this anterior choroidal artery is giving rise to small branches that irrigates this optic tract. Let's go to see the anterior cerebral artery. This is the smaller of 2 terminal branches of the internal carotid artery. It's almost the double. For example, middle cerebral artery is the double in size like the anterior cerebral artery. This is A1 and M1. Look the size of this middle cerebral artery and the size of these anterior cerebral arteries. This artery arises at the medial end of the Sylvian fissure. Here we have the Sylvian fissure, lateral to the optic nerve, lateral to the optic chiasma in here. and below the anterior perforated substance. It courses anteromedial above the optic nerve or chiasm, and below the medial olfactory striate to enter the interhemispheric fissure. Near its entrance into the fissure, it is joined to the opposite anterior cerebral artery, like in this case, and ascends in front of the lamina terminalis to pass into the longitudinal fissure between the cerebral hemispheres. This is a close view in which we can see the optic nerves, the prechiasmatic cistern, supraclinoid carotid artery, middle cerebral artery, and anterior cerebral artery. These are some perforators, small branches that are coming from M1, known as the lenticulus striates arteries. Another picture, another view of these beautiful arteries, supraclinoid segment, supraclinoid carotid artery, and then the posterior communicating artery, anterior choroidal artery, and the branches of M1. In here, we can see this A1 segment of anterior cerebral artery and some branches that are coming from this small anterior communicating artery. The microvascular anatomy of the anterior communicating artery shows great variability in its shape, diameter, and length, presenting fenestrations, duplication, and triplication. The anterior communicating artery has an average length of 6 millimeters with a diameter of 0.8 to 4 millimeters, an average of 2 millimeters. A single anterior communicating artery is present in only 60% of the cases. The A1 is the favorite site on the circle of Willis for hypoplasia. A1 hypoplasia has a high rate of association with aneurysm. It is found with 85% of anterior communicating aneurysm. Let me show you this video. I am separating here the frontal lobe. This is second, the A1 and A2 anterior communicating artery, very short. As you can see, they are too close. Some anterior cerebral artery with the other one. And let me show you some small branches that are coming directly from anterior communicating artery. These small arteries are going to the anterior hypothalamic and the lamina terminalis and optic nerves. This is a brain without injection. So the injection of arteries is really easy to do. So the only one you need is to a complete brain, and with the arteries well preserved. So you can cannulate these arteries and inject the latex or also silicone. Here we have the anterior communicating artery. This is another variation, anatomical variation of this artery. This is A1 in the left side, anterior communicating artery. Some of us could think that it is fenestrated, or other ones could think this is not a fenestration. This is only A1 in the right side that is going to the frontoorbital area, and this is an azygous variation of this artery. So it depends your vision, your opinion of this. So here we have a brain, the optic nerves, and olfactory strias. The circle of Willis. A1 segment send branches to the anterior perforated substance. Most of these arteries arise from the proximal half of the A1. These arteries, small branches of A1. The Wilder's, or also known as thermic artery, originates from the anterior communicating artery and is found between 1.5% to 12% of the brain. This is the thermic artery, also known as Wilder artery. As you can see, this is coming from this segment, anterior communicating artery. Here we have another circle of Willis. Here we have anterior cerebral artery, A1 in the right side, A2, A1 in the left, A2 in the left, and this is the anterior communicating artery. Supraclinal segment of this artery, the middle in the right side, and posterior communicating arteries. So in this case, we have the basilar artery, the apex, and we have P1 and P1 in both sides. This is hypoplastic, and the posterior communicating artery in this case is known as fetal variant. This is in both sides. Here we have a short video to show you the optic nerves, some arachnoid, the rectus gyrus, olfactory stria, A1, and anterior communicating artery. You can see also some small branches that are coming from A1, and here we can see the recurrent artery of Hübner. The origin of this recurrent artery or Hübner artery is in the first millimeters of A2. So this is recurrent artery of Hübner. So I'm going to separate this the longitudinal fissure in order to see A2 in both sides. These are the first orbitofrontal artery coming from A2. This is recurrent artery of Hübner, this one. Look at this. This artery turns posterior to go to the anterior perforated substance. Hypoplastic, short and long anterior communicating arteries are also observed, as well as the presence of communication between both anterior cerebral arteries due to the union of their respective walls, but without a real formation of a true anterior communicating artery. like in this case, this artery is joining with the other anterior cerebral artery, and I could say that there is no a real anterior communicating artery. This is A1 left side, A1 right side, optic nerves, chiasma, infundibulum, and this is a supraclinal segment, supraclinal carotid artery. And here we have the apex of the basilar, P1 in the left side, hypoplastic, and in the other side, here we have the P1 and P2. Its importance lies in the number of perforating arteries. It originates with a range of 1 to 11 perforating arteries, with a diameter between 500 microns and just under 100 microns. Because of their vascular territories that they irrigate, they are divided into 4 regions: lamina terminalis and hypothalamus, anterior commissure, septum pellucidum, paraolfatory gyrus, subcallosal region, and the anterior region of the cingulate gyrus and genu of the corpus callosum. The number of branches originating from the anterior communicating artery is small, usually 0 to 4, and they supply the suprachiasmatic area, the dorsal surface of the optic chiasm, and the anterior perforated substance. This is anterior perforated substance. These branches have been classified as short and long, the former supplying the lamina terminalis and the preoptic region of the hypothalamus. The subcallosal artery, which corresponds to a long branch, supplies the anterior commissure and the septal area. The recurrent branch, in this picture, look at this. I could A1 and supraclinal portion of the internal carotid artery in order to see this recurrent artery of Hübner. As you can see, this artery is, these are two arteries. 1874 is unique among arteries in that it doubles back in its parent anterior cerebral artery and passes above the carotid bifurcation and middle cerebral artery into the medial part of the sylvian fissure. Before entering the anterior perforated substance, it pursues a long, redundant path to the anterior perforated substance. The recurrent branch is the largest artery arising from A1 or the proximal 0.5 millimeters of the A2 in the majority of hemispheres. Here we have this recurrent artery coming from the A2, and the other one, same, A2. There was a single recurrent in 28%, 2 in 48%, and 3 or 4 in 24%. If there were 2 or more recurrent arteries, both or at least one arose at the level of the junction of A1 and A2. Rarely, those more than a single recurrent artery arise from the A1. If there are 2 recurrent arteries and one arises on the A1, the second usually arises at the junction of A1 and A2. A large basal perforating artery may infrequently arise from the A1 between the anterior communicating artery and the recurrent artery. This artery enters the anterior perforated substance as a single stem or divide into many branches. The distal part of anterior cerebral artery. The distal or post-communicating part of the anterior cerebral artery begins at the anterior communicating artery. Here we have anterior communicating artery. The distal anterior cerebral artery is divided into 4 segments, A2 through A5. The A2 is infracallosal. Here we have the corpus callosum, and this is the A2. Begins at the anterior communicating artery and terminates in the junction of the rostrum and genu of the corpus callosum in here. A3 precallosal segments extends around the genu of the corpus callosum and terminates where the artery turns sharply posterior above the genu in here. This is third segment. The A4 supracallosal and A5 post-callosal segments are located above the corpus callosum and are separated into an anterior A4 and posterior A5 portion by a point bisected in the lateral view close behind the coronal suture. This is in an imaginary line that passes through the foramen of Monroe. This is from here to this part is A4, and from here to the posterior part is A5. The cortical branches supply the cortex and adjacent white matter at the medial surface from the frontal pole to the parietal lobe, where they intermingle with branches of the posterior cerebral artery. 8 cortical branches are typically encountered. They are orbitofrontal, frontopolar, internal frontal, paracentral, and the parietal arteries. The internal frontal group is divided into the anterior, middle, and posterior frontal arteries, and the parietal group is divided into superior and inferior parietal arteries. Let's go to see middle cerebral artery. Middle cerebral artery arises as the larger of the 2 terminal branches of the internal carotid artery. The diameter is about 4 millimeters, roughly twice that of the anterior cerebral artery. Its origin is at the medial end of the sylvian fissure. This is sylvian fissure. This is an open sylvian fissure, and lateral to the optic chiasma, below the anterior perforated substance, and posterior to the division of the olfactory tract into the medial and lateral olfactory stria. The middle cerebral artery is divided into 4 segments: M1 sphenoidal, M2 insular, M3 opercular, and M4 cortical. The M1 begins at the origin of the middle cerebral artery and extends laterally within the depths of the sylvian fissures. It courses laterally, roughly parallel to an approximately 1 centimeter posterior to the sphenoid ridge in the sphenoidal compartment of the sylvian fissure. This segment terminates at the site of a 90-degree turn, the genu located at the junction of the sphenoidal and operculo-insular compartments of the sylvian fissure. M1 is subdivided into a pre-bifurcation and post-bifurcation part. Here we have an early bifurcation. So M1 insular sphenoidal segment, sphenoidal segment is from the bifurcation of supracranial carotid artery and to the site where this artery make a 90-degree curve. So here we have another picture in which we can see M1, sphenoidal segment, insular segment, opercular segment, and these are some branches of cortical segment. Let's go to see this small video. I want you to see the beauty of these arteries that are coming from M1. This is a posterior communicating artery. And look at this. This is really beautiful. The lenticulo-striates artery coming from M1. These are really interesting arteries. because you know the site, the origin of an hemorrhagic in the brain, in the lenticular region, are caused by rupture of these lenticular striated arteries. In a persons with a history of hypertension. This is the end of M1, and this is M2, opercular. These are two trunks. One is temporoparietal and the other temporoparietal, and the other one frontoparietal. The M2 segment includes the trunks that lie on and supply the insula. This segment begins at the genu, where the middle cerebral artery trunks passes over the limen insulae and terminates at the circular sulcus of the insula. These are circular sulcus of insula. The greatest branching of middle cerebral artery occurs distal to the genu, as these trunks cross the anterior part of the insula. The branches passing to the anterior cortical areas have a short path across the insula than those reaching the posterior cortical areas. Here I am doing dissection of this opercular segment in the insula of a dissected brain.
From the sulci and gyri of this insular lobe of the brain.
The M3 segment begins at the circular sulcus of the insula and ends at the surface of the sylvian fissure. This is M3 segment. This is opercular. This is M2 insular segment and M3 opercular segment. The branches forming the M3 segment closely adhere to and goes over the surface of the fronto-temporoparietal and temporal opercula to reach the superior part of this region. Look at this video. I am going to separate some portion of M3. This is M2. Insular segment. These are branches of opercular segment. Some of these arteries are well injected, other ones could not be injected. I also removed some parts of the parieto frontal region and also the temporal. In order to see much better this region, the insular region and opercular segment of this middle cerebral artery. The M4 is composed of the branches to the lateral convexity. They begin at the surface of the sylvian fissure. This is the surface of sylvian fissure, and extend over the cortical surface of the cerebral hemisphere. Let's go to see this injection of these arteries. The more anterior branches turn sharply upward and downward. upward and downward. After leaving the sylvian fissure, the intermediate branches follow a gradual posterior incline away from the fissure, and the posterior branches pass backward in nearly the same direction as the long axis of the fissure. If we inject with silicone or latex, we could get not only good videos, good pictures. This is a really good exercise in order to make better surgical procedures in the brain. Look, the small arteries can also be injected with this technique, like in here. These are really, really small arteries that could be injected in this way. The cortical area supplied by the middle cerebral artery is divided into 12 areas. This is a Roton drawing. Here we have the orbitofrontal area. This is this one. In the brain, below, we can see this region. The prefrontal area is the superior part of the pars orbitalis, the pars triangularis, and the anterior part of the pars opercularis, and most of the middle frontal gyrus. Here we have the orbital and pars triangularis. In here, the orbital, pars triangularis, and opercular area. Here we have the prefrontal area. The precentral area, the posterior part of the pars opercularis and the middle frontal gyrus, and the inferior and middle portions of the precentral gyrus. Here we have the precentral region. Here we have the precentral region. The central area is the superior part of the precentral gyrus and the inferior half of the postcentral gyrus. Here we have this area, the anterior parietal area and posterior parietal area. The angular area is the posterior part of the superior temporal gyrus. Here we have the angular area, and here we have this area in the brain. The temporo-occipital area, posterior temporal area, middle temporal area, anterior temporal area, and temporopolar area. All of them are very important in doing some surgical procedures. The posterior part of the circle of Willis. This is one of the most difficult sites to approach surgically. The complex series of perforating vessels surrounding and arising from it and its intimate relationship to the extraocular nerves and upper brain stem. Its branches are exposed in surgical approach to the basilar apex, tentorial notch, lateral anterior ventricles, and inferior temporal. So here we have the posterior part of this cycle of Willis. Here we have P1 in the right side, P1 in the left side. This is hypoplastic. And here we have an fetal variant of this posterior communicating artery. The apex of basilar artery, and here the supracerebellar arteries. The posterior part of the circle of Willis, this is one of the most difficult sites to approach surgically. The complex series of perforating vessels surrounding and arising from it and its intimate relationship to the extraocular nerves and upper brain stem. Its branches are exposed in surgical approach to the basilar apex, tentorial notch, lateral anterior ventricles, and inferior temporal. Look this beautiful video
arterias perforantes
to see the posterior part of circle of Willis. Here we have the basilar apex. P1, this is oculomotor nerve, and these are perforators that are coming from P1, anterior thalamo perforating artery. This is the posterior perforated substance, mammillary bodies. Another view of this region. This is a really, really beautiful region of the brain and the arteries. This is basilar apex, P1 in the left side, P1 in the right side. And this the posterior communicating arteries. Look at this. This is really interesting and beautiful. The anterior thalamic trunk. This is a perforating artery. Some arachnoid. If you inject a brain, you can differentiate very well the arachnoid and the small, very small vessels like this. This is P2 segment in the posterior cerebral artery. Let's go to see this sagittal cut of the brain. And here we have the thalamic region, the brain stem, and these small branches, perforating arteries that are coming from P1. Mammillary body, the hypothalamus, and chiasma. These are some branches of P2. The fetal configuration in which the proximal posterior cerebral artery is small, like in this case, look at this. This is P1 in the left side. And this posterior communicating artery, like this, provides the major supply to the PCA and is larger than the P1, like in this case. A normal configuration, and no, this is not normal, because posterior communicating artery in the right side is bigger than this one. So in both sides, we have a fetal variant. A hypoplastic arterial segment is defined as one having a diameter or 1 millimeter or less. Like in this case, this is this is a hypoplastic arteries. The posterior portion of the circle of Willis sends a series of perforating arteries into the encephalon and midbrain. Some of the perforating branches arising from the upper part of the basilar artery overlap with some of those arising from the posterior circle. The risk of occlusion of these vital perforating vessels during tumor or aneurysm surgery include visual loss, somesthetic disturbances, motor weakness, memory deficits, autonomic imbalance, diplopia, alteration of consciousness, abnormal movements, and endocrine disturbances. Another video. to look this
Aquí voy a separar
interesting,
esta que
to look this interesting region. The posterior perforated substance, mammillary bodies, the oculomotor nerves. In this case, I did not identify, I did not see a posterior communicating artery in the right side. The posterior communicating artery continues with PCA in the right side. And in this case, this branch in the bifurcation of the basilar apex is giving rise to some arteries for the peduncle. The complexity in clipping aneurysm from the apex of this basilar artery depends of the number of these perforators. The P1 segment, also called the precommunicating segment, extends from the basilar bifurcation to the junction with the posterior communicating artery, P1 segment here, in which the P1 has a smaller diameter than the PCOM, and the PCA arises predominantly from the carotid artery, occurs in approximately 1/3 of hemispheres. A normal configuration in which the P1 segment is larger than the PCOM-A is found in nearly 2/3 of hemispheres. A few hemispheres will have a posterior communicating artery and P1 of the same diameter. A fetal configuration may be present on both sides. The relatively constant branches arising from the P1 are the thalamo-perforating artery, which by definition enters the brain through the posterior perforated substance, the thalamo-perforating arteries. This one. The medial posterior choroidal artery directed to the choroid plexus in the third ventricle and lateral ventricle, and the branch to the quadrigeminal plate and rami to the cerebral peduncle and mesencephalic tegmentum. Here we have the tegmentum of the mesencephalic region. This is a close view. This is a very nice view of these perforators. P2 segment. The P2 segment begins at the posterior communicating artery, lies within the crural and ambient cisterns, and terminates lateral to the posterior edge of the midbrain. The P2 is divided into an anterior and posterior part. Because the surgical approach to the anterior and posterior halves of this segment often differ, and because it is helpful in identifying the origin of the many branches that arise from P2. The anterior part is designated as P2A, or crural or peduncular segment, because it courses around the cerebral peduncle in the crural cistern. The posterior part is designated P2P, or the ambient or lateral mesencephalic segment, because it courses lateral to the midbrain in the ambient cistern. I cut the temporal lobe, and we can see also in this picture another important arteries like lenticulostriates arteries and the anterior choroidal artery. And also we can see the hippocampus in here. this is another nice, beautiful picture. We can see the absence of a posterior communicating artery. The posterior cerebral artery is coming from the supraclinoid carotid artery. And in this, in the apex of the basilar apex, is giving rise to this large but thin artery that is going to irrigate the peduncular portion of the brain. These are another pictures of the crural and ambient cisterns and some branches coming from P2. Another pictures. Here we have the fourth cranial nerve, the trochlear nerve, and P2, P2A and P2P. The thalamo-geniculate arteries arise directly from P2 beneath the lateral thalamus and penetrate the part of the roof of the ambient cistern formed by the geniculate bodies and surrounding area. The posterior cerebral artery most commonly gives origin to 2 or 3 thalamo-geniculate arteries. These are thalamo-geniculate arteries. This one. But there may be as many as 7. They arise near the junction of the crural and ambient segments, with a nearly equal number arising from each segment. The P2A begins at the posterior communicating artery and courses between the cerebral peduncle and uncus that forms the medial and lateral walls of the crural cistern and inferior to the optic tract, and basal vein that crosses the roof of the cistern. To enter the proximal portion of the ambient cistern, the P2P commences at the posterior edge of the cerebral peduncle at the junction of crural and ambient cisterns. Crural and ambient cisterns. This is P2. It courses between the lateral midbrain and the parahippocampal and dentate gyri, which form the medial and lateral walls of the ambient cistern below the optic nerve, the optic tract, basal vein, and the geniculate bodies and the inferolateral part of the pulvinar in the roof of the cistern and superomedial to the trochlear nerve and tentorial edge. Hippocampal arteries. This is an interesting artery. The hippocampal artery, if present, arises in the crural or ambient cistern and is the first cortical branch of posterior cerebral artery. It supplies the uncus, anterior parahippocampal gyrus, hippocampal formation, and the dentate gyrus. Look, this is an hippocampal artery, this one. This is really, really nice. This is hippocampal region. The P3 or quadrigeminal segment proceeds posteriorly from the posterior edge of the lateral surface of the midbrain and ambient cistern to reach the lateral part of the quadrigeminal cistern and ends at the anterior limit of the calcarine fissure. The PCA often divides into its major terminal branches, the calcarine and parieto-occipital arteries. Here they are, parieto-occipital arteries. The average length of P3 is about 2 centimeters. P4 segment includes the branch distributed to the cortical surface posteriorly. It begins at the anterior end of the calcarine sulcus. Here we have P4. So thank you so much. I want to say that most of the text written in this lecture was obtained from a giant of anatomy, of brain anatomy. Thank you to Albert Rotten. And to all of you, especially Dr. John Bennett, for doing a great effort for education in neurosurgery and neuroanatomy for many countries around the world. I am very honored for this invitation. Thank you, John Bennett.
Yeah, Victor, this is how it can work. You can have a presentation on neuroanatomy and have someone like Atul Goel just drop in. This is just the way this tool is fantastic. Greetings, Atul. Welcome.
Thank you, John, for this wonderful, wonderful, unbelievable anatomical presentation by Victor. I think Victor is one of the stars of neuroanatomy and one of the most gentlemen that I have seen, and the way he demonstrates the anatomical demonstration, the dissection that he does is absolutely wonderful. And these kind of dissections are mandatory for all young and old and all neurosurgeons. This dissection, what he has shown today, will be helpful to learn the anatomy, to perform the surgery, and to be safe. I think, John, this is a big contribution from your side to invite Victor on this Neuroanatomy TV. I think this forum of yours will certainly, there is no doubt that this forum will be the most popular forum of neurosurgical anatomical TV. And Victor, congratulations to you for this beautiful, beautiful presentation.
Well, I hope all the neurosurgery students in the world get to know Victor. And we also are graced with the presence of Vlad Benez, a big neurosurgeon from Czechoslovakia. Hello, Vlad. Welcome.
Hi. I fully agree with Atul. It was amazing, amazing dissections and amazing videos. Victor, it's really great. Thank you for the presentation. It was I have learned a lot myself, actually.
Thank you, Dr. Vladimir. Thank you, Dr. Atul Gol. This is very, very, I feel very honored because of your opinions. You are one of the best brain surgeons around the world. And to have an opinion like you is really important for me. Thank you.
Okay, the floor is open. Does anybody wish to comment or say something to Victor? Great. Now, Young Hung, are you there? So, I'm not picking. Are you there, Young Hung? He's a neurosurgeon from China. Are you there, Warlex? How are you? Warlex, can you make a comment?
Wonderful.
When I'm stuck, Warlex, I'm going to call on you.
I mean, like I have to do like operations every day to assist my teacher on aneurysm. So it's always nice to have like amazing teachers to teach again and again about anatomy.
Well, you know, I didn't know the community of neurosurgeons. I'm not a neurosurgeon, and I took neuroanatomy, but I didn't realize how serious they were about learning it. Do you have anything to say? Go ahead. I'm sorry.
I mean, but we will never bore of learning because we was asked every day if you still like learning. Teacher keep asking you the same arteries, and maybe someday you can answer, someday you cannot answer. Something like that.
Very good. Okay, any more comments? Francesca Pazaru, are you there? Or you just came for the Kahoot game? Are you there?
Yeah, I'm here. Thank you for the presentation. It was really interesting, and I really think I learned a lot. I'm here with Mate, actually. He's learning how to say thalamoperforators.
Yeah. She was making presentations before pregnancy, right, Francesca?
Yes, and I think I'll be making more since I'm pregnant again, and I'll be staying at home for 1 year.
Oh, okay. Yeah, you're welcome to. You're welcome to. You were a great announcer. Okay, Young Hung, are you there? I just wanted to introduce a Chinese associate because we're making headway in China too. Go ahead. Whoever talked.
Thank you, Victor. It's a very beautiful presentation and very beautiful anatomy pictures. It's very important for our neurosurgery. This is basic anatomy knowledge for our surgery, for our do some aneurysm and the scope base. It's very important for us. Very, very good job. Thank you, Victor.
We'd like to see
Thank
that.
you, good friend.
We'd like to see that statue that Victor gave you. Do you have that little statue there with you, Young Hung? Do you have the
Yeah.
you have the head, the statue of the head that Victor gave you?
Yeah.
The scalp.
Oh, there we go. Let's
Yeah.
see it. Let's see it. Let's see it. There we go.
Yeah.
That's from Mexico, right?
Mexico, yeah.
Okay, very good. Okay, more comments or questions? We're going to take a quiz now, and please be patient. It's called Cahoots, but essentially, let me get the game up here to explain what's going on. This is a quiz of the content that Victor just lectured about. And basically you access the website. Let me show you where you access. As a matter of fact. Okay, we're gonna start this. Okay. This is with your smartphone. Okay, we're getting the pin. Okay, this is a pin. Okay, you go with your smartphone to kahoot.it and then you punch in that code 8029006. Okay, yeah, there we go. Someone's quick. And we'll just wait till people get in there. We'll give it a few minutes to let everyone get in. No hurry. Okay, wait a few more minutes. We can get more people in. Oh. Be patient, we're still loading up. Game pin 802. I'm coming in myself. 02 9006. Okay, we're getting more. Okay, I think we're okay. We got a couple more. Okay. Oh, no, just 1 minute. See, Okay, I think we're ready to start. Okay, basically, you're using your smartphone to pick the answer. Okay, here we go. On your smartphone now, pick the color of the answer. Okay, we'll go over the answers later. Okay. Would you rather go over it later, Victor, or go over it right now? What do you want to do?
As you want, Bennett. This is correct. 8.
Okay, okay. Well, can you just talk about that if you want? We'll go over each question, the correct answer. Okay.
Yeah.
Can you make a comment about this question? Is there anything to comment on? Perhaps not. Okay, we'll go on to the next one. Is that the right answer? Oh, I guess we can go over the right answer. Is that the right answer, Victor? Number 8, 4 parts?
Yes, correct.
Okay, good. Most of the panelists got it right. Okay, next question. And you can see your own scores there if you got it right. Okay, looks like a overwhelming Victor Cavernous. Is that the correct? That's the correct answer. That's very good. I guess people were listening. Okay. See, a lot of people got that one right. Majestic Sloth is at top. Okay, an overwhelming majority, vestibular artery. Is that correct, Victor?
Yeah, correct.
Oh, we got some good students today. Shellful ferrets pulls that ahead. The artery of Wilder. I never heard of that. Okay. Okay. Well, I hope is that correct? Wow.
Yeah.
We got some good students here today. Another right one. Wow. Okay. Very good. Cheerful ferret takes over for majestic sloth. We have 20 questions, so hang in there. 20% of cases, the ophthalmic.
Number 6. Okay, number 5. Okay.
Okay, well, I don't know, Victor. What's the answer there?
The correct is false. It's too much. 20% of cases is too much.
Too much. What is the right number about?
Less than 8%.
8%. Okay.
Number 6.
Okay. Proud Rhino takes over. Pre-mammal. I didn't ever heard of pre-mammillary. Okay. But I'm not a neurosurgeon. Okay. PCOMA.
Right.
How is that? That's
Right.
correct, Victor. Great.
Right.
Great. Okay. Proud rhino pulls out head now. Okay. Utter of Wilder also.
Maybe this is repeated, but no problem.
Okay. Oh, it's a repeat question. Okay.
It's an exercise, a good
Okay.
exercise.
Okay. Yeah, we'll get better at using this platform. Okay, that's the same answer there. We'll just quickly go over that one.
Okay.
Okay, clinical feature of occlusion of the ACHA is characterized by. It's a tough one. Okay, contralateral hemiplegia, hemianesthesia, and hemianopsia. That's correct. That's great.
Right. Right.
Wow, that's great. That was a tough question. Okay, proud rhino maintains the lead. The first segment of the MCA is named. Okay, overwhelming sphenoidal, Richter.
Right.
Okay, great, great. Most of the questions, okay, we'll just keep rolling along. We got a lot of questions here. Lenticular striate branches arise from. Okay, sphenoidal segment. Correct. That's great. Majority. Another winner. Okay. Middle cerebral artery is divided in 4, 3, or 5 segments. Okay, very good. 4 segments. Victor, is that correct?
Right.
Oh,
Right.
man, fantastic. Okay, rhino is widening the lead. The cortical segment of the middle cerebral artery irrigates the next areas except.
Correct.
Okay. Oh man, this group is hot. Maybe they studied, Victor. Proud rhino widens the lead. The recurrent artery, also known as Hubner artery, usually arises from.
Right.
Overwhelming.
Wow.
Victor, wow. I think
Most
maybe they should be teaching. Wow, 10,000 proud rhino is an anatomist in the making. Okay, 11.
Yeah. Right.
Man, oh
Right.
man, that's getting us staying hot. Okay, let's see what happened to proud rhino. It's even bigger lead. Okay. Okay, anterior part of choroid nucleus. Is that it, Victor?
No, this is the color yellow.
Okay.
Yeah,
Anterior part of caudate nucleus.
anterior part of caudate nucleus and anterior third of putamen.
Okay, that's not bad. That's the first one that's been way off. Okay, let's see. Proud rhino maintains the lead. Okay, posterior cerebral artery, great. In 4 segments, another one on the money.
Yeah.
Proud rhino. Whoop, the lead shrinks a little bit to 800 points. The medial posterior choroidal artery arises from. Okay.
Right.
That's great. That's great. Okay,
Right.
and another good one. Let's see what happened to Pride Rhino. Whoop, I'm sorry. I punched that too soon. Okay. P1, P2, or P3? Okay, medial core. Is that correct, Victor?
This is P2.
Okay, so it's blue. It's blue. Okay, so we're a little off on that one.
Yeah.
Let's see if that. Yellow buffalo comes from behind, nudges ahead of Proud Rhino. All right, Proud Rhino, it's time to get to work. Infarction of the area supplied by the thalamo-geniculate arteries. Okay, true. Well, Victor?
Yeah, there's letter A, true. Yes. Yes.
Okay, great,
yes.
great. Okay, great. Okay, let's see what happened here. Yellow Buffalo maintains the lead. I think we're down to the last question, Proud Rhino. Got to bet it all. Severe memory loss and a deficit resembling Korsakoff syndrome may be caused by bilateral occlusion of. Okay, Victor. Hippocampal.
Yes,
right.
right,
Excellent. Excellent way to end. Let's see here. The final tally on the podium. Proud Rhino's number 3. Majestic Sloth is number 2. Yellow Buffalo. Okay. Okay, Yellow Buffalo. Well, okay, great. How'd you like that, Victor?
Yeah, really nice.
That was
he won a spine like this.
Oh yeah. Well, I think that's a better choice than what Warlith suggested a body part, but I don't know if that would be appropriate. I don't know if that would be appropriate. What do you think, Warlick?
Brain part.
What's that?
Brain part.
Okay.
I pick like which brain part that you like.
Oh, the caudate nucleus. I don't know why. Hey, what'd you think of that, Warlocks? You like that?
Yeah, that's amazing. Like it's a great tool to get attention from the people. Maybe before start the meetings to see improvement.
Yeah, we kind of got hurried. We started in a hurry, so we weren't able to set it up. But yeah, maybe putting the questions before the as Victor
Yeah.
suggested. And what else can we do, Warlicks, to improve the broadcast?
John,
Oh, okay, Atul, go ahead.
John, can you, this is a wonderful way of letting people learn, enjoy, and then test themselves. But I want to ask you a question. Can
Yes.
we avoid the phone and can we just work on the computer? No? Is that not possible?
What do you mean? What do you mean?
Means I don't want to open my phone now and start working. I
Right.
want to just see the image and click on the image. Is that possible?
Oh yeah, yeah. You can do that from a laptop. Can you play the game from a laptop? Is that what you're saying?
Yeah, yeah, that's right.
Yeah, yeah. You can. You
My
can.
laptop to play.
Yeah.
I play from my laptop, not the mobile phone.
Oh, that you. Yeah, I played from a laptop too,
Yeah, I play
and
from
I also played from the smartphone. So either one, a tool I think will work.
yeah, I
Yeah.
play on my MacBook. Work.
So if it works on the laptop or on the computer, that will
Yes.
be absolutely great. I tried, but John, it didn't work. So I probably didn't do it right.
Okay. Well, we can test it out. Let me just end the broadcast. We'll test it out. Okay.
Yeah, yeah. Okay,
Okay.
okay.
Thanks everyone for coming, and we'll see you next week.